medicines and medical devices. So somehow we can say we are very lucky because normally this is someone, let's say, from the other side, you know. So because he is from the German administration allowing all kind of medicines, yeah. But he's not the man deciding about anti-conceptional pills, so don't be afraid. Yeah, he studied in Regensburg in Bavaria near Munich, and became a doctor there. Then he worked in the United States for a couple of years, and nowadays he is a pharmacologist, not only in the mentioned authority, but also he's giving the side of that lessons at the University of Hanover. So I ask for some little applause for Erich Schneider.
Okay, good morning together, and thanks to the organizers for giving me the opportunity to give this little talk about the psychological effects of hormonal contraception. I want to add to Lotta's introduction that I'm here only as a private person, so it's not necessary to know where I work in Germany, which job I have. It's not the opinion of my agency. I'm just here as a private person because I'm interested in this area of research. And I'm also not actively working in this area. Now, okay, so I just work it. I need the next slide. Okay. So when we hear of estrogen or progesterone, we mostly think first about the organs and tissues that are important for female fertility and for the sexual function, but these receptors, the binding sites for these hormones, they are also present in the brain. And this is an image I took from this publication here. And you can see that there are different areas with these receptors. The frontal cortex, for example, is important for problem solving, for the execution and planning of actions. The thalamus is important for coordination of sensory perceptions. The hypothalamus, I think we all know because it is releasing the gonadotropin releasing hormone. It's the active control center of the female cycle, you could call it. The amygdala is a very small area but densely packed with estrogen and progesterone receptors. It's important for learning, memory, and emotions. The hippocampus is important for long-term memory. The cerebellum is crucial for everything which has to do with movement sequences. When you learn something, a certain movement sequences, for example, playing the piano, it's very important to have cerebellar function. So it is not surprising that psychological side effects are the main reasons for dissatisfaction with hormonal contraceptives and for the discontinuation of such medicines or such substances, because we have definitely many possibilities how these substances can work on the brain and can act on the brain. And what is relatively well known is, of course, the increased risk of depression. I don't want to talk a lot about this because we all know it, that the pill may cause depression, at least in some women. But I just want to show you a representative paper which is from 2016, but still very interesting. It's from Skovlund et al. Was a Danish study conducted from 1996 to 2013 and included almost 500,000 women aged 15 to 33 years. And it turned out that hormonal contraception increased the risk for a first suicide attempt by 97%, so almost a doubling of the risk, and the risk for completed suicide tripled, and specifically the young women 15 to 19 years were most susceptible to this side effect. And when we look at this graph from the publication, then we see that within 1 month of pill use, the risk increases already and stays up for at least 1 year. And when it decreases here in the succeeding years, this is not really that the pill is more tolerated if you take it longer, but this is just a sign that the women who didn't tolerate the pill dropped out of the study, so the entire population gets somehow distorted and only those who are resistant to the side effects remain. So this is what we know about the strong effects of the pill when it really leads to a clinically manifest depression and leads to a diagnosis that qualifies for antidepressant therapy. But the question is, maybe this is only the tip of the iceberg, and we have maybe just a lot of more side effects that are more subtle and are not so easily diagnosed in clinical practice, but somehow influence the relationship between men and women when the woman takes, for example, oral contraceptives. And I have found one publication from last year, Hampson et al., from 2024, and they used another kind of psychological test to see whether there are subtle subconscious differences in women taking contraceptives versus those not taking contraceptives. And I will explain that on this slide. They included 62 healthy women from 18 to 26 years in their study, and they were taking standard combined oral contraceptives for at least 3 months, so the median intake time was 12 months. And as we all know, in case of the most contraceptives, we have a kind of contraceptive cycle, which is certainly not a real cycle, but you take it for 3 weeks and then there's some break where you have an artificial bleeding, kind of a menstrual bleeding due to the discontinuation of the hormones. And so these authors said, well, let's just compare the behavior of a woman while she is taking the contraceptives and then compare it to the behavior in this week where she doesn't take the hormones. And they did 2 sessions, one after 14 to 21 days of hormone intake. This is the so-called active group. And then the same women were tested again after at least 3 days of not taking hormones in this pill break, the so-called inactive group. And they did 2 kinds of tests. So the first one, the explicit test, was the so-called profile of mood status questionnaire. Explicit means that if you fill this questionnaire, you have to actively think and reflect about your state of mind, about your emotions, and this may somehow bias the response you give, because you have a longer process of thinking, which many different factors can influence. And so they also use implicit tests that are tests where you have to give an immediate response without thinking a lot. And from these implicit tests, I just take the first one as an example and skip the others due to time reasons. I take as an example the facial emotion identification task I will show in the following slides. Now let's first have a look at the result from the explicit test. This POMS, Profile of Mood Status test, has 65 questions, and you had a scale of 0 to 4, 5 options to respond from not at all to extremely. And several mood dimensions were analyzed. Most important for our purpose here is anxiety, depression, anger, and rigor. And the interesting thing is the authors had a subgroup of women, of 15 women, who already reported to be slightly depressed. So they thought, well, let's analyze them separately and see if the pill works different in these women who are already a little bit negatively biased and depressed versus those who have not such problems, who don't have such problems. And the result is surprising. It's the opposite of what we would expect. When we look at the total group of women, we see that those who don't take the pill are more anxious, slightly more depressive, and slightly more angry. And when we look at the women who have this negativity bias and are slightly depressed already from the very beginning, we see that the differences become even larger. So where does this come from? I mean, normally we would expect that the effect of the pill is just the other way. And maybe the problem is that it is such an explicit test where you have to reflect more about your emotions, about the situation you are in, and maybe the fact that after discontinuing the hormones in the last week of this pill cycle, you have kind of a menstrual bleeding may just lead to a worse mood and to some impairment in emotions. And another factor could be that if you have a combined oral contraceptive, you have, when you discontinue it, first the estrogen component disappearing from the blood, and then the progesterone component just stays a little bit longer. And maybe this has also some depressive effect, because we know that the progestin preparations, the mono preparations, are specifically bad in this regard. So it's a strange result. We just leave it here and look at the implicit test. And here I have chosen from this paper the facial emotion identification task. And this is the presentation of 96 images with 6 basic emotions: sad, angry, fear, disgust, neutral and happy faces. And the woman is asked to quickly rate which emotion is shown in the picture and press a button to identify the emotion. And the median time to press the button is recorded. And we know from other experiments published in other papers that depressive persons need a little bit longer to press the button when they see angry or sad faces, negative emotions, because if you have a depression, you are more captivated and focused on negative images, and for some reason it leads to a delay in pressing the button. Maybe you are just so captivated by the image that it takes a little bit longer to react. And when we look at the entire group of women, we don't see much difference. There's maybe some tendency that the angry faces are detected with a little bit slower response time in those taking the pill, but I wouldn't take this difference too serious. But when we look at the women who were already a little bit depressed in the beginning, we see that first they all need a little bit longer, so this confirms the notion that depressive people have a longer reaction time, and when they take the hormones, then it's additionally longer than when they don't take them. So there may be some subconscious effect that leads to a higher negativity bias, although when you ask them, they still will tell you, well, I'm not depressed, I feel well, but you see there may be subtle effects that you do not actively realize, but that may somehow influence already your behavior. Now let's turn away from the area of depression and let's go to the area of attractiveness and how the male partner rates female attractiveness at the different phases of the cycle and when she takes oral contraceptives. And there's a paper out there which is a little bit strange. So you see the ideas crazy scientists can have. So they just went to nightclubs and interviewed striptease dancers, asked them how much money did you make per shift, and at the same time they also asked them, do you take the pill or do you have a natural cycle? And then they created this curve, and you can see that around ovulation they earned most of the money, and those who took the pill, they had a worse outcome in terms of money. I mean, of course, we don't have to discuss about the moral and ethical implications of women doing such things, but it is definitely interesting that somehow the attractiveness to the men visiting these nightclubs is in fact influenced by the fertility status of the women. And there are also more serious studies done, for example the one by Kobe et al. In 2013, and they asked the participants to rate the attractiveness on the scale from 0 to 100, and when the women were in the fertile phase, they were rated slightly more attractive than in the infertile period of their cycle, and when they took oral contraceptives, it was also a little bit lower than in the fertile period. But you can see these results are really very weak, and you have already here cut off the scale at 40, and it's fairly significant, so we shouldn't take it too serious, but maybe it's just a matter of how you conduct a study. In this case, two groups are compared, one taking the pill and the other one not taking the pill, and you have large variability because every woman reacts somehow differently. So it would be possibly better to analyze the behavior or the attractiveness rating in a relationship in the same couple when the woman takes the pill and then doesn't take it. So if you have this within couple or within individual comparison, you may get even larger results. Certainly there are some women in some relationships that don't are absolutely not influenced by the pill, and others may be strongly influenced. So this is very variable. An interesting finding in this paper was also that the male self-perception seems to change. So the male partner rates himself more attractive when the woman is in the fertile phase compared to the infertile. And when she takes oral contraceptives, it's even a little bit worse than Okay, so this was the second area where I just wanted to say, show you some subtle effects. I know everybody who knows a little bit about statistics can say these are really shaky, small effects, but you never know what happens in real life to a specific couple in a specific relationship, whether this plays a role or not. Now the next thing is, I wanted to tell you about this voice analysis. So there were analyses done that follow the voice of a woman over the cycle and compare, and there's one paper that even compared them with contraceptives and without contraceptives. And I'm absolutely not an expert in voice analysis, so I had to read a little bit more about it, because the most important parameter here is the so-called fundamental frequency. And so I did a self-experiment and just set the vowel U at high pitch and low pitch, about 1 octave difference, and recorded it, and these are the two sound recordings. And this I use as an example now to explain what fundamental frequency means. So when I zoom in into the 25 millisecond part of the high pitch, then you see there are several humps and shoulders. It's not a clear sinus wave. It is a mixture of several frequencies. But what you can see is that the same pattern is repeating again and again. And this is repeating at a period of 4 milliseconds, which fits 250 times into 1 second. So this is a fundamental frequency of 250 hertz. Now I set the same vowel again, 1 octave deeper, and you see in the sound recording, now it looks quite different. So you have many, many different frequencies mixed. It looks more chaotic, but when you have a closer look, you see that the same pattern repeats 3 times. This is the second time, the third time. So in this case, it's 8 milliseconds, it's twice as long. So you have a frequency of 125 hertz. So if you halve the frequency, you are 1 octave deeper. So everything fits together. So this is what is meant with fundamental frequency, is the frequency in which a certain pattern in the sound recording repeats. Now, there's one paper by Banai. I think it was done in Croatia, and they analyzed the fundamental frequency of women who don't take hormones, and you again see these large error bars. So I would have problems publishing that, but if you have nothing else, and these are the first results in this area, it's certainly worth it, and it's certainly worth to look further into these results. And here you see that the pitch of the female voice seems to be slightly higher around the late follicular phase, but when they use hormonal contraceptives, and in this case they just differentiated in the contraceptive cycle between equivalent periods, so they also had some kind of menstrual, late follicular and luteal phase, but of course it's not a real cycle, so they just took the corresponding days and named it in this way. That's why I put it in quotation marks here. But you can see that this increased pitch around late follicular phase seems to be gone in the same part of the so-called pill cycle. But again, I wouldn't say this is something I would really take too serious, because the statistical variability is so high. They found that it is significant, but they didn't show the figures, so I created the figures myself, and when I saw that, I think, well, maybe we have to do more research on that. But nevertheless, there may be some effect, and there are several papers out there that show that the voice of a woman changes over the cycle. And there's also one publication recently that says it is important to whom the woman talks. So it's not just you say something and record the voice, but it's also important with whom she interacts. So there are also differences in changes. Then there's a so-called harmonics to noise ratio, which is a measure of how clean the voice is, so how musical and clean. And if it is lower, the voice is a little bit rougher and it's not as clean. And you can see in those taking the pill, it seems to be that the voice is a little bit has a little bit more background noise or underground noise. Now, we just leave it there. As I said, you should interpret this with a little bit skepticism, but it is interesting to see that there are such studies, and it will for sure be interesting to see what we will get in new results in the coming years. Now, the last effect I want to talk about is the sense of smell, which also changes throughout the cycle. And here was one publication by Hoffman, Renfro and Hoffman. It's already 2013, relatively old, but I didn't see anything that says the opposite since then. It was only a small study with 16 women with a natural cycle and 17 taking oral contraceptives, and they tested the ability to detect musk odor. So musk, now it doesn't work anymore. Doesn't have anything to do with Elon Musk. It's just a fragrance odor which is used in fragrances, which is identified as a typically male smell, male odor. And without oral contraceptives, we have this certain threshold. I don't have to go into details now how it is measured, but you can see when the women take oral contraceptives, the threshold gets higher, so it's more difficult for them to detect, and this is certainly a subconscious process, these typically male odors. Another example is androstenone, which is a metabolite of testosterone. And also here you see this difference in threshold, detection threshold between ovulation and luteal phase, and when they take oral contraceptives, it's just worse. So it's really a very high threshold to detect these odors. I mean, it's controversially discussed how important pheromones are really for humans. So it's known that in animals it's very important, but maybe it has some subconscious effects on the way how men and women relate to each other. Interestingly, lemons, peppermint, and rose scent were also tested, and there was no difference. So even if the wife takes the pill, the husband can still bring roses, and she can. So, what can we conclude from that? There's one hypothesis. When we have these subtle symptoms in various areas, so what happens to a relationship when a woman, for example, first meets her later husband or long-term partner while she is taking the pill and later stops taking it, or the other way around, when she meets her husband, her later husband, when she does not take the pill and later starts taking it. And then there was this publication from 2014. Roberts called this the congruency hypothesis. So when the pill-taking behavior is congruent, always the same from the beginning into the relationship, then they hypothesized that it is better for the relationship than when the behavior changes. And they looked at various parameters. I only have shown here the sexual satisfaction parameter, and it seems to be higher when the woman met her later husband while not taking the pill, and she also continues not to take it. But when she later starts taking the pill, it seems to be a little bit disadvantaged at least for this parameter of sexual satisfaction. And it's also the other way around. When she was on oral contraceptives in the beginning and then stops taking it, then the sexual satisfaction is lower as compared to those couples where the woman just continues taking it. So if there's a disruption, something changes, of course, in the partner and in the relationship, and this may somehow be sensed and may have some effects. In male partners, they couldn't observe such effects. Now, it's interesting, but research is going on, and this year they published a meta-analysis. It was another group, and they couldn't confirm it. So they said, we looked at 7 studies with 13 effects where they compared groups of women taking the pill and others not taking the pill, and they couldn't find any confirmation of this congruency hypothesis. However, when they looked at within-subject effects, so there were some publications reporting also the same woman while taking the pill, while not taking the pill, then they saw some support for this congruency hypothesis, and they conclude that when this effect exists, it's very small, and it's probably, it's only important for certain couples and certain women, but for sure not for everybody. Now, you see there are many questions open. One question I didn't address here is, for example, that there are many differences between the preparations. There are the mono preparations only containing progestin components. There are the combined pill preparations, and in this case the combination partner can also vary. So there are many things that have to be studied, and you saw that these studies are always very small. We don't have many results in this area, and there's really a great lack of knowledge. But we can summarize that the receptors for the hormones we have in the brain, and of course the brain function, the psychology is influenced. We have these profound changes which we all know, depression for example, but we also may have some subtle changes people are not so much talking about, like these subclinical effects in these implicit depression tests, subtle effects on attractiveness rating, even the self-perception of the male partner. Changes in female voice may be somehow influenced by the pill. Changes in the perception of pheromone-like odors. And there is the hypothesis, which is controversially discussed, that it may have some effect on the quality of a relationship when the pill-taking behavior is incongruent when it changes, and there's some break then. As I said, more research is required, and many factors have to be considered. I thank you for your attention and hope it was just an interesting little glimpse into these more subtle effects we are not talking so much about, but for sure an interesting area of research. Thank you for your attention.